Please welcome Tess Warboys and Melinda Brassington, who will be presenting around the abstract Can Occupational Therapy, Hand Assessment and Treatment Sessions be conducted via Telehealth? Please make them welcome.
Thanks, Matt, for that introduction. So I'm Melinda and this is Tess. And thank you for attending. We'll be talking about our research that we've completed around can OT hand assessment and treatment sessions be conducted via telehealth. So just a bit of background. It's been shown that over half of all injuries that occur are to the upper limb, and of these it's quite commonly the result of manual or farm work. The nature of these injuries may be from a single traumatic accident, which could result in a tendon or fracture, for example, or the injuries may be more the result of repetitive use, which can lead to conditions such as RSI and carpal tunnel. Hand therapies provide an evidence base for us as therapists that guide the type and frequency of the treatment that we provide for these hand conditions. So, often individuals living in rural and remote areas are required to travel to metro or larger regional centres to access specialist surgery and initial treatment of their hand injuries. Ideally, following this initial phase of care, hand therapy services should be provided at a local level for the individuals. In the southwest, there are 3 hub sites in Charleville, Roma and St George, with an OT based in each of these towns. We outreach to a large geographical area of over 319,000 square kilometres and an estimated population of 26,000 people in that area. The distance of the towns that we cover range from 40 kilometres to 400 kilometres from our hub site. Outreach is generally a set frequency and it's based on the caseload. There's often a disparity between the outreach frequency and the recommended treatment outlined in protocols. So for example, we go to Augathella every 4 weeks and we may have a client there requiring weekly hand therapy. So telehealth is definitely a feasible solution to this access challenge for our rural and remote clients. Although there have been no studies to date which have specifically examined the validity of delivering OT hand therapy sessions via telehealth, other evidence supports the potential for this model. LAID in 2012 conducted a study which demonstrated the successful use of telehealth for physiotherapy clients with elbow disorders, and Langen's study in 2013 found that an upper limb therapy program was able to be successfully provided using telehealth within the client's home. So the aims, as you can see on this slide, of our research, the primary aim was to examine the level of agreement for clinical decisions made by the telehealth OT and the face-to-face OT during hand assessment and treatment delivered via telehealth. And our secondary aim was to examine both the patient and clinician satisfaction of using this telehealth service as a delivery model for hand therapy. So the study design, we used a non-inferiority study design for our research. All patients were simultaneously and independently assessed by both the face-to-face and telehealth OTs, and the results were later compared to determine levels of agreement. Each session was led by the telehealth OT, who initiated the session at their end and assessed the patient with the assistance of an allied health assistant who was with the patient at the remote site. The face-to-face OT was also located in the remote site and completed their own assessment of the patient. So participants were recruited from a cohort of adult patients referred to the OT departments in the southwest with a hand injury between October 2015 and April 2016. Our exclusion criteria omitted any patient who was attending for an initial assessment, those who required fabrication or adjustment of a splint, clients requiring initial compression bandaging, any clients with significant visual, hearing or cognitive impairment, individuals who did not use English as their primary mode of communication and required an interpreter, and any patients under the age of 18. Our sample size was 18 clients. And as you can see from this slide, there was a nice spread of data with a mix of gender, patient location and injury types. Okay, I won't push her off. There was a range of injury locations and treatment administered, with the majority of people requiring exercise prescription and revision. And you can see nicely on this slide all the different types of treatment that we were able to provide using this model. So 4 OTs participated in the research, and we had varying degrees of experience of treating hand conditions, ranging from 1 to 12 years. The original treating OT was present in all sessions, and the OTs were randomly allocated the role of either face-to-face or telehealth. All the allied health assistants were required to have a Certificate 4 in allied health assistance, and prior to participation, they all received a minimum of 1 hour face-to-face training, which included managing the video conferencing system, reporting on subjective information and scales, and the correct use of equipment used in gathering objective information. So that involved training in using a tape measure, dynamometer, pinch gauge, and goniometer. So our methods. The telehealth session was conducted using live video conferencing through the Queensland Health Secure Network. During the session, the telehealth OT collected their assessment data through a combination of patient consultation, direct observation of the hand and appearance, including the scar, and that was using the telecamera images. And we also directed the allied health assistant to assist in getting the objective measurements. The face-to-face OT used the same data collection form whilst making their own assessment of the patient. The face-to-face OT was responsible for patient safety throughout the session, and they were able to override and correct any decisions made by the telehealth OT if necessary. However, this did not need to occur. The AHA's role was to establish the telehealth session at the remote end, ensure written consent was obtained, gather resources and equipment, and assist with the collection of objective and subjective information as directed by the telehealth OT. They were not involved in making any independent diagnostic or treatment decisions. So we developed a purpose-built data collection form, and we used this form to structure and format the session. It included, but was not limited to, the outcome measures that you can see on this slide. At the end of each session, the telehealth and face-to-face OT reported as to whether they thought the session was successful or not, and the suitability of using telehealth for managing that particular client. The total duration of the session was recorded, as was any general technical, audio, visual or patient behaviour issues which impacted on that session. Following each session, patients and the telehealth OT completed a satisfaction survey. Agreement between the telehealth and face-to-face OTs was calculated using percentage exact agreement, and a level of equal to or greater than 80% was used to represent a clinically acceptable level of agreement. And our satisfaction ratings were collapsed to indicate percentage of respondents who agreed, were unsure or disagreed with statements.
So moving on to the results now. These were the objective measures that we collected, and all our objective measures achieved equal to or greater than 80% PEA between the face-to-face OT and the telehealth OT. These are our subjective clinician ratings. For all these ratings, all parameters met equal to or greater than 80% PEA. As you can see, these are our patient-reported parameters. All these parameters met equal to or greater than 80% PEA. So we achieved quite high PEA in this area, which indicates a lot of what the patient was reporting via telehealth, we were able to pick up on the other end very accurately. Although PEA met criteria on all parameters, an error analysis was still conducted to examine if there was anything to learn from any of the differences between the face-to-face OT and the telehealth OT. Most errors were expected errors, for example, clinicians differing by 1 to 2 points on perceptual rating scales. However, the most notable errors were associated with the objective measures, particularly the goniometer readings, which revealed issues with the allied health assistants' use of this equipment. This did not impact the study results, session outcomes, or treatment recommendations, however highlights the importance of training and checking allied health assistants are comfortable and familiar with using all equipment. There were 9 instances where the visual quality of the system was low. However, clinicians indicated that the quality of the session was only impacted in 3 of these 9 sessions. For one session, the telehealth OT was unable to see a patient's scar or a particular detail of the hand, and therefore required the allied health assistant to email through a photograph of the patient's hand. In 2 instances, the audio quality of the system was noted to be low. However, this did not impact the quality of the session. There was one system dropout during a telehealth session, which was reconnected with no further issues. And the average session duration was 49 minutes. This is the outcome of our patient satisfaction survey. I won't read out each question we asked, but I will highlight a few of the questions. So 100% of the time, the patients agreed that they were comfortable to use the telehealth system if it was available at the nearest facility. And none of them reported any difficulties seeing or hearing the telehealth OT, as you can see down the bottom, 0%. 94% of the time they felt they had sufficient time to follow instructions given during the session. And at the bottom there, only 17% indicated that they would prefer to have a traditional face-to-face consultation despite the possible costs and inconveniences. So that's a relatively small percent. In terms of our clinician satisfaction, again, I'll just highlight a few of these. So 100% of the time the clinician was satisfied with the level of rapport generated, and they were 100% satisfied with the audio quality of the system. The top 2 questions here relate to the visual quality of the session and the therapist's ability to satisfactorily and competently assess and treat the client. So these were our lowest scores in the satisfaction survey. And if you think back to when I said there was 3 sessions impacted by low visual quality, this relates to the satisfaction from the telehealth therapist. This pilot trial found high levels of agreement between subjective, objective, and patient-reported data collected simultaneously by the telehealth OT and the face-to-face OT. There was also high levels of agreement regarding therapy activities and decisions regarding patient progress and session outcomes. Both patients and clinicians were positive about their experience with telehealth. Overall, the findings support the use of telehealth as a feasible method of delivering hand therapy. A number of limitations pertaining to this study design are acknowledged. Firstly, this was a pilot study, and a larger scale implementation may identify issues that were not observed across the 18 sessions. For example, the ability to assess and manage wounds was not explored in this study. As no patients presented with a wound during the study period, the accuracy of the system to support wound management still needs to be determined. It is important to note that the telehealth model explored in this study required an allied health assistant to be present at the patient end to assist with data collection. Unfortunately, not all services will have access to a trained allied health assistant, which may limit the delivery of this hand therapy model tested in the study. Furthermore, the need for an allied health assistant to be present at the patient end limits the ability to provide a hand therapy service in the patient's home. Further service enhancements could be achieved by utilising software measurement tools, eliminating the need for the allied health assistant role, and enabling greater flexibility for patients to access this service from their home. Implementation of a telehealth hand service model has capacity to enable all patients, particularly those living in rural and remote areas, to access specialist services to ensure hand therapy is delivered at the frequency recommended by best practice treatment protocols. Before ending, I'd just like to acknowledge our mentors throughout this project who provided endless expertise, encouragement and support, and that is Professor Liz Ward and Dr. Patria Cornwell. We'd also wish to acknowledge our funding body, the Health Practitioner Research Scheme, and the Roma and St George Hospital OT departments for their use of equipment and in-kind support, the South West Hospital and Health Service Allied Health Assistants, and the South West Hospital and Health Service management team for their enthusiasm and encouragement to engage in research. Thank you.